All right. Good afternoon, everyone. I'm so delighted you're here. My name is Dr. Katie Ryan, and I'm the Director of Arts and Humanities in Healthcare here at the CU Center for Bioethics and Humanities. And I've had the pleasure of being part of this incredible center for 13 months now. I'm continually impressed by the innovative work and collaborative spirit that defines the University of Colorado as a whole and this center in particular. The interdisciplinary approach that we foster here has been both inspiring and invigorating. I'm particularly thrilled to feature Dr. Dawn Owens-Robinson's works today, as it beautifully weaves into the narrative we've been exploring through the quilts in our gallery at the Fulginity Pavilion, just outside this door and to the right for those of you who haven't been in the gallery before. Dr. Owens-Robinson's contributions add a vital layer to the story we're telling about health, community, and resilience. Dr. Dawn Owens-Robinson's story is deeply intertwined with the history of this very institution. She was born right here, where CU Anschutz now stands, while her father was an active duty Marine. As a Denver native, Dr. Owens-Robinson attended Denver Public Schools and graduated from George Washington High School. Her childhood in Denver was rich with activities from martial arts and dance to cheerleading and skating across the city with her family. Dr. Owens-Robinson's academic journey began at CU Boulder, where she earned her bachelor's degree. She then pursued her medical degree at the University of Cincinnati. Today, she works near Boulder as an OBGYN with over 23 years of experience. In addition to her clinical work, she serves as a medical malpractice expert witness and consultant. Her commitment to improving maternal and infant mortality health is evident in her involvement with the various women's health committees. She has been an active member of the Kalamazoo and St. Joseph County Fetal Infant Mortality Review Committees, as well as the Michigan and Colorado State Maternal Mortality Surveillance Review Committees, among others. In a full circle moment, Dr. Owens-Robinson recently joined the University of Colorado Foundation Board of Trustees in November 2023. Since returning to Colorado in October 2022, she has been actively engaged, especially with CU Boulder's campus, but I'd also like to claim her as one of ours too. Dr. Owens-Robinson currently resides near Boulder with her family and her dog, Holly. Holly? Yes. This lecture comes at a particular poignant time as we near the closing of our powerful art exhibition, Raw Material Quilts by Nedra Bonds, and just outside of here, 7,000 Babies, on the legacy of Justina Ford, the first Black physician practicing OBGYN in the state of Colorado. The intersection of Dr. Owens-Robinson's research and Bonds' artwork in particular provides us with a unique opportunity to explore the complex issues surrounding Black maternal and infant health through both scientific data and artistic expression. Nedra Bonds, like Dr. Owens-Robinson, has deep roots in her community and a long history of activism. Her quilts serve as visual testimonies to the lived experiences of Black women, much like the data that Dr. Owens-Robinson will present today. For instance, Bonds' quilt, The Finger and the Fist, created in response to the shooting of Michael Brown in Ferguson, speaks to the systemic racism that Dr. Owens-Robinson will identify as a factor in Black maternal and infant mortality. And just outside this room, as you read about the history and the power and the impact of Dr. Justina Ford's work and legacy in this community, you will hear similar themes about the grit, the hope, the joy, and the humor that is needed to push back on these devastating trends. As we listen to Dr. Owens-Robinson's presentation, I encourage you to keep in mind the visual narratives created by Bonds. All of these women in their respective fields are bearing witness to the experiences of Black women in America. Dr. Owens-Robinson and Justina Ford through rigorous clinical practice and bonds through fabric and thread. As we delve into the sobering statistics and complex social determinants of Black maternal and infant mortality, let's remember that behind every number is a story that both Dr. Owens-Robinson and Nedra Bonds are committed to telling, each in their own powerful way. With this connection in mind, and with great appreciation for her local roots and extensive experience, please join me in welcoming Dr. Dawn Owens-Robinson.
Taller than me. As she stated, my name is Dr. Owens-Robinson. I'm going to apologize in advance if I have to quiet my phone. It's on vibrate, but because I have hearing aids, the ringing will still go on in my ear if I don't stop it quickly. So that's why my phone is here. So today we're here to talk about an important and pertinent issue. I remember the data started coming out initially. I remember ProPublica putting it out pre-COVID about the maternal death rate in America. And then the data and the information started coming out about Black and brown mothers. So we'll get started today. Also, I believe Kathy may have mentioned, as of May of this year, I'm actually the statewide obstetrical chair for the Colorado Maternal Mortality Review Committee. And I've been doing that work for 10 years. So it can be emotional. If you feel you need to step out and get a breath of fresh air, please feel that you can do so. We're gonna get started. I'm tired of being one of the few Black doctors on the unit, in the department, in the hospital, and at the conferences. I am tired of our Black and brown mothers not being heard. Recent studies show that 40 to 50% of our mothers state that they were not heard throughout their entire pregnancy course, including postpartum. I am done with systemic and institutional racism affecting generations of Black and brown people in regards to our health, our wealth, our housing, our education, and our job opportunities. Why are we here? Slavery, Jim Crow, the GI Bill not being funded for Black vets, redlining, structural, institutional, systemic racism, school segregation, lower incomes due to less opportunity for better jobs and higher ed. Why are we here? Dr. Arlene Geronimus in the 90s termed a theory called weathering of the Black body. And she demonstrated in 2010 that Black women in their 40s and 50s, that their telomeres, which are the chromosomal markers for aging, show that our bodies are 7.5 years older than our white counterparts. Why are we here? Some of us, since we're at a medical school, may be aware of the Flexner report. The president at the time asked Dr. Abraham Flexner to review the medical schools. And in 1910, he decided that 5 of the 7 Black medical schools needed to close. The AMA estimates that that's led to a deficit of 30 to 35,000 Black physicians to provide care for us and to serve as mentors for our youth. I am a mother, a daughter, a sister, a granddaughter, a niece, an auntie, and a BFF. I am a cisgender Black and Filipino OBGYN, a physician who practices by the golden rule. That's how my mother raised me, regardless of race, age, sexual orientation, education, income, or type of insurance. I treat my patients with the same dignity, humanity, and respect that I would want for my family. Slide. So I have no financial disclosures, and my opinions are my own and do not represent those of Advent Health. Slide. So today I'm going to talk about the World U.S. statistics on maternal and infant mortality and calls to action. Slide. This is the newest addition to my family. He was born February at this facility. And for some reason, it was probably the most nervous I've ever been, but I know why, because the data is fresh in my mind and my heart. So it was probably the toughest one. Next slide. In 1966, in Chicago, MLK stated that of all inequities that exist, the injustice in healthcare is the most shocking and inhuman. Next slide, please. The Commonwealth Fund was founded by Anna Harkness in 1918. Her mission was to provide high-performing, equitable healthcare to society's most vulnerable. This is the slide from 2022. I do. So in this slide, you can see the green slides recommend the United States, the green bar graphs. And in 2022, white women were dying at a rate of 13.1%, where you can see African-American women were dying at a rate of 55. And what we know is the United States is one of the wealthiest, but we're one of the sickest population or group of people. And we have one of the highest maternal and infant mortality rates for developed countries. Slide, please. In this graphic, the Commonwealth Fund shows this data, like actually in 2019, Norway had not a single maternal death. And the slides that are close to 5 and just above that, those countries are the countries that have the highest presentation of midwifery integration in their healthcare systems. Midwife moms die less. And the World Health Organization has stated that in systems where midwifery is well integrated, there's less C-sections, better healthcare expenditures, and less maternal deaths. Next slide, please. By the World Health Organization, this is just a color graphic that keeps it simple. In 2017, our maternal mortality rate was only 17.4. So we are in the pale pink mode. But then next slide, just 3 years later, our maternal mortality rate jumped to 23.9. And you can see where the worst maternal mortality rates are in Central Africa. In 2020, the World Health Organization stated that a mom died every 2 minutes throughout the world, and that 800 women died that year every day due to preventable causes, which with what the Maternal Mortality Review Committees found in Michigan and Colorado and the CDC, we believe 89% of maternal deaths are preventable. Next slide. We're at a med school. Most of us have probably heard of primary. This is the March of Dimes slide speaking on maternal healthcare deserts. 1/3 of Colorado's counties are maternal healthcare deserts, meaning there's not an OB, there's not a midwife, which probably means there's not a doula, and there's no labor and delivery birthing facility. And that map represents 1,119 counties throughout the country. 36% of those are in the South and Midwest. Based on demographics and location, that affects a large proportion of Black, poor, and rural mothers. Next slide. This is the CDC data representing 2018 to 2021, again, demonstrating the maternal mortality rate on the left shows it increasing from 17.4 to 32.9 from 2018 to 2021. And then the next set of bar graphs are the brown and Black women. So where white women were dying at 26.6% in 2021, we were dying at nearly 70, not percent, 70 per 100,000 live births. I didn't define that. Maternal mortality is a number of deaths per 100,000 births. Next slide, please. This is the CDC data showing the same information in 21 and 22, showing the stark discrepancy between Black, white. The Asian moms fare well, sometimes better than the Caucasian mothers, but you can see that our Black mothers, Black and brown mothers, have a significant higher maternal mortality rate. Next slide. This is another graphic showing that maternal mortality rates peaked in 2021 with 1,205 moms dying that year. And the most recent data still being collected thinks that 30% of those deaths were due to COVID. Next slide. This is another graphic showing maternal deaths. Again, the lower rates are the non-Black population, and you can see our rates rising in 2018 from up to the highest level of 69.9. That other steep peak where it's flat for a while is where we started monitoring our Indigenous mothers, and their rate of death started at 49.2 and escalated to 118.7 in 2021. Next slide. So we know in the United States that Black mothers are dying at alarming rates across all education and economic levels. According to a New York study in 2016, educated Black middle-class mothers died at a higher rate than poor, uneducated, unhealthy white mothers. They could walk into the same hospital, a good maternity unit, and still have worse outcomes. In New York City, their review has shown that we're more likely, 9 times more likely to die than our white counterparts in New York City. And most of us have heard of Serena and Beyonce's complications. Serena had to stand at the desk and scream to get a postpartum CT scan, despite the fact she had a pulmonary embolus before. Despite being one of the most famous Black women in the world, she still had to fight to have her voice heard. An example again that education doesn't save us. Dr. Shalon Irving was the epidemiologist in the Department of Maternal Fetal Science at the CDC. And despite having 2 PhDs, 2 master's degrees, and several certifications, on day 15, she died. In all the visits, no one drew a lab, did a chest x-ray, did an EKG, did an echo of her heart. And her mother went with her to every visit, and she died. So education didn't save her. A pediatric hematologist recently released her story of her C-section. She felt bad from the beginning. She went back in, got readmitted. Her own hospital system refused to hear her voice. She had to call her big brother, who worked at the facility, to call administration, to get a surgeon to come in. And the first thing the surgeon did was apologize for the level of care that she had received. And so he said, "I'm sorry that you had to go through this, but I pray that it's going to make you a better doctor." And that's the care that a pediatric hematologist got within her own walls, where people saw her, but obviously they didn't see her, nor did they hear her. And then most recently this year, we heard about the former Kansas City chief cheerleader who died of sepsis after losing, I think, their second child. So, and they, I think that first pregnancy, I don't know if it was a miscarriage, but anyway, this was their second child, and now her husband has no family. What we do know is that 52% of maternal deaths occur after delivery. I remember in the ProPublica series 7 years ago, a postpartum nurse in an East Coast hospital was like, "I didn't know about postpartum preeclampsia." I think my heart fluttered that a nurse taking care of postpartum mothers would admit. I don't think her name was in the story, which is probably good. But what we do know is that we have more cesarean sections. We are more than twice as likely to be readmitted to the hospital in the first. We have more hypertension, more cardiomyopathy, which means our heart is not pumping correctly. And those are the 2 leading killers of us. In white women, what my current review of all the cases for the state of Colorado has shown, and before I left Michigan, white women predominantly are dying from overdose and suicide and homicide, but Black women are dying from obstetric complications predominantly. We are also twice as likely to have depression and more than 50% less likely to get treated. Next slide, please. This is the Colorado Maternal Mortality Review Report that came out last year. I was not a part of these reviews. This report is available on the internet at the Colorado Department for Public Health and Environment. What they found in that 5-year period is that we had 174 deaths. 26.2% of them were 89% again. Twice as likely to die. Native American indigenous moms were 3 times more likely to die. And what their review showed is that 2/3 of those cases. And when we review discrimination, that's your Medicaid, your insurance, your education, that you're 22 with 5 kids, that you're obese, that you have mental illness, that you have domestic violence, substance abuse. Those are all reviewed, and that's not inclusive. Those are the things we look at in the lens to say, was this woman at some time had suffered discrimination? And sometimes it's not in the records, but we are calling the importance to review the problems from that lens. And as I stated above, the primary causes are overdose, suicide, homicide, and then the obstetric complications. Sepsis, which is life-threatening infection, blood clots in the lungs, or something called an amniotic fluid embolism, which is very critical. I've had 2 patients survive that in my career. And during this 5-year review, we found that 50% of the deaths were substance abuse and mental health, I'm sorry. What they also found is that our Medicaid moms had a 10.5 times higher risk of death, and that our moms that did not achieve more than 7 times increased risk of death. Next slide. This is a summary slide of the cases they reviewed that said they suspected up to 7.1% of the cases probably had some likelihood of discrimination. Next slide. Now, if we talk about infant mortality, the infant mortality rate in 22 was 5.6. The provisional data, so infant mortality is the number of deaths in the first year of life per 1,000 live births. So moms, it's 100,000, per babies, it's 1,000. So in the US, it was 5.6. The provisional data this year shows it's down to 5.48. And again, in this slide, you can see that Black and brown babies die at 2 to 3 times the rate of white moms. The next slide shows the Colorado data is the same. Black babies are dying at 10.9 per 1,000 births compared to white babies at 4.4. The leading causes of death in newborns are birth defects, low birth weight, sudden infant syndrome, maternal complications such as preeclampsia when we have to deliver moms at 24 weeks, and respiratory distress syndrome. Next slide. What the Commonwealth Fund found, which we kind of all heard, is that we know the US is the only country of developed countries that doesn't have universal health. We also have the lowest life expectancy. We also have the most avoidable and treatable conditions. Again, we have the highest maternal infant, and we have the highest suicide rate.
I would just ask if you could
Come back.
just in the microphone, because there are 100 people online, and when you move, then they can't hear you.
All right.
I'm sorry.
So I'll repeat the slide. In the US, we're the only country of industrialized countries that does not have universal health coverage. We have the lowest life expectancy, the highest rate of avoidable and treatable conditions, the highest maternal infant mortality rates, and the highest suicide rates. New paragraph. Midwives, midwives, midwives. CU was just fortunate to attain a grant that's going to allow them to train 14 midwives to provide midwifery care in rural Colorado. And 2 of those students are African-American. I met them in May. Again, as stated, the World Health Organization believes that midwives are an evidence-based approach to reducing maternal mortality. That high-income countries with the lowest intervention rates, best outcomes, and lowest costs have integrated midwifery-led care. And in this slide, you can see at the time of this study, 2020, of this slide generation, that we only had 4 midwives per 1,000 live births. As you descend on this slide, the countries that have 66, 68, 40, 50 midwives per 1,000 live births, their maternity mortality rates were in that bottom part of that slide, where it's been steady for years. And one thing I learned when working in Dubai with midwives and nurses and physicians that trained in the UK, when a mother dies, the whole country knows because they're one healthcare system. So if something is noticed to have been a mistake or something was not done quick enough, I can't remember the name. It's not an inquisition, but it's a public meeting anybody can attend. And if there's a problem found, they can fix it throughout the whole system because they're all their national healthcare system. So just examples. So we know based on maternal midwifery presence, Sweden's maternal mortality rate was 4.3, Australia's was 4.8, and at the time of this slide, ours was 17.4. Next slide. This slide shows midwifery presence in healthcare. The darkest colors is where they are the most. The white colors are where they are the least. In the states where midwifery presence is deep rooted in the West, in Arizona and states like that, they have lower cesarean section rates. They have more vaginal deliveries, more deliveries after C-sections, and less complications. Where direct contraindication to the states that are shown in pale gray and white, Mississippi's maternal mortality rate is 82.5. They also have one of the largest populations of Black people in Mississippi. Ohio's is also high, Alabama is high. And science and studies have shown that midwives save lives. Next slide. As do doulas. Midwife doulas, that's my chant. Doulas have been shown to decrease cesarean section, increase breastfeeding rates, decrease postpartum depression, anxiety, PTSD, decrease the use of epidurals. And for those who don't know, doulas are maternal healthcare advocates. They're a voice for the patient, the family, through pregnancy, through labor, and postpartum. And so those of you that don't know, our state leaders put bills into action that as of this fall, family Medicaid patients get free doulas. So now the goal is to increase the number of doulas in the state. So if you have family or friends on Medicaid, make sure you spread the news, because I haven't gone to the Medicaid site to see how well they're marketing this, but it's a major, major deal, because back when ProPublica came out, that's when the first studies about doulas came out. And just like midwifery came over with us from Africa, we were the originators of the doula care also as Black women. Currently, there are over 24 states that have current laws paying for Medicaid or in the process of implementing coverage for Medicaid patients for doulas. We do have many resources in the community, Mama Bird, Family Forward Resources, Birthing Serenity. If anyone's interested in doulas, sometimes the cities and counties will also pay for doula training. And the training is variable because there's not a mandated process yet. It could be a weekend, it could be up to 6 months. So be careful where you get your training so that you can be as informed as possible. Next slide. So the World Health Organization has a few things that they consider call to action. And the best way to prevent maternal deaths is to prevent unplanned pregnancies. So they feel all women, include adolescents, need full access to contraception, safe abortion services to the full extent of the law, and quality abortion care. Next slide. Again, I'm the cheerleader for expanding midwifery and doula care in the US. We know that paid maternity care is important, and we're the only industrialized country that does not provide it. Paid maternity care allows the mother to heal physiologically and psychologically while ensuring the financial security of her families. Most other industrialized states mandate at least 14 weeks of paid leave from work, and several countries, the Norwegian countries, mandate a year and even give the father a year off. Next slide. I'm sorry, go back. That was a busy slide. We're also one of the few industrialized countries that doesn't provide universal maternity care. And as most of us know, Medicaid did expand in over 30 states to include the entire year after delivery, which is key because 52% of maternal deaths occur after delivery. On that slide also is the discussion about, go back, sorry, is home visits. I know when I was in Georgia, there were some home visitation programs, but in some countries like Germany, the moms get 10 visits plus 16 additional visits the first 8 weeks. Netherlands, they get 10 days, minimum 4 hours each. And so the World Health Organization recommends at least 6 visits, home visits. And what this allows is for someone to go in, usually a nurse or a social worker, which gives you insight into the mother-baby dynamic, the mother-partner dynamic. Is there food in the refrigerator? Are the lights on? Do they have money for formula if breastfeeding didn't work out? It allows you to assess the mental well-being of the mother, the partner. Is there domestic violence going on? And also home visits like doulas and midwives have improved breastfeeding success and decreased healthcare costs. Now I'm ready for the next slide. Thank you. So again, we have to address the inequalities of access and quality reproductive, maternal, and newborn health services. Again, universal health coverage for moms and babies. We must address the causes of maternal mortality and prevent the majority of these deaths that are occurring. We must strengthen the data collecting systems. Until recently, and it's still not quite uniform of how maternal deaths are documented on death certificates. Federally, each state has been allotted money now to develop a maternal mortality review committee. When I worked in Michigan, they just started theirs in 2000, I'm sorry, Indiana just got their MMRC in 2018. Michigan's is almost 60 years old. So they've been doing the work for decades. And also ensuring accountability to improve equity and quality care. Next paragraph. I think we also must expose our children to science and to physicians and to nurses and to midwives. Again, we have a deficit of 30,000 to 35,000 doctors due to the closure of the Black med schools, but there are 2 new Black medical schools that are going to be starting at Xavier and Morgan State in the next few years. And during COVID, New York University's Grossman School of Medicine gave free tuition. The rate of Black enrollment increased 142%. Next slide. The AMA does state that enrollment in non-HBCUs is increasing for Black students. In 2015, it was only 7.2, but it's still only 10.4 as of last year. They have a program where they send med students and doctors into local districts, local schools, to expose the children to what they can dream to be. Because I think it's hard to attain what you can't see. So for me, all it took was my grandma and Marcus Welby and Quincy, and that was enough. I wanted to be a doctor, but my grandmother was a labor and delivery nurse. So I had the insight into that during the stories. I'm also old enough to have been a candy striper at Mercy Hospital across from City Park. So that's where I got my experience pushing the little book in a snack cart. The AMA said their ultimate goal is to generate a physician workforce that more closely resembles that of our nation. Currently, right now in the US, Black physicians make up 3 to 4% of the entire physician population. To improve enrollment, Bloomberg Philanthropies has donated a 4 years, $100 million fund to increase enrollment for Black medical students. Next slide. So for the Colorado MMRC, what they recommended is, again, systems that provide pregnant women and parenting persons healthcare that addresses the impacts of oppression and racism. We must continue to partner with the doula organizations, the MMRC, all the other organizations in the city and the state that are working to save moms. We have to come together, and that's one of my goals, to communicate and have open communication. And we also must continue to put on events like Friday and Saturday, the Colorado Black Women Political Action had a 2-day event, and I participated in two panels on Black maternal health, and I'm doing the same with the National Moms Tour on October 26th. So I think people hear it, but I think they don't really understand the significance and the impact. I can't remember the exact year, but Charles Johnson IV was the husband that led the fight to get the Momnibus from the federal government. His wife died at Cedars-Sinai Grace in Beverly Hills Hospital, Beverly Hills. So they had the insurance to get in the door, but the hospital's done such a poor job in taking care of Black and brown women that it's now under federal investigation, because she had a scheduled C-section and didn't leave the hospital because the doctor didn't report back to the bedside for hours and hours and hours. And all they were doing were pouring blood in her. So when they went to try to save her life, everything they had put in her was in her abdomen, and she died. And she's a Cedars-Sinai Grace in Beverly Hills. So change definitely needs to happen. We need to continue to work with our city, county, government, and community leaders. We must vote so that we have our state and national leaders to lead our fight. And we must continue the fight of being Black in America. We need to be hopeful, compassionate, empathetic, and steadfast. We must not get discouraged or overwhelmed. Next slide. This is my warrior family. From the age of 5, when I told my family I wanted to be a doctor, no one ever said no. Everyone pushed me to do it and to go forward. Next slide. And this is my warrior sister. Some in this room know her by name, but this is her fourth grandchild that was due in February. And she and her grandchild are here because on February 23rd, 2005, the St. Joe's Labor and Delivery Unit heard my cousin say that my sister was hemorrhaging. They responded rapidly, and St. Joe's had just got uterine artery embolization like 4 weeks before. And they called me in Georgia to say, I'm like, get off the phone and save my sister. So after they did that, I sent them fruit and flower baskets. But their response and them hearing a Black woman saying another Black woman was in trouble is why my sister is here and has 4 beautiful grandchildren. So that presentation of my sister being heard comes down to just us listening, to society listening. Because when we're heard, when we're respected, when we are valued, when we are treated with humanity, we survive, we live, and we thrive. Thank you. Questions?
Just a note for those of you in the room, if you press the button on your microphone, you just have to tap it once and it'll turn on now. So new development in this room. Maybe 100 folks.
Okay. Oh, most importantly, this data is available, as I said, at the CDPHE for everyone to review. Yes.
I'm just curious, in one of your slides, you had, Michigan has mandatory training in implicit bias. And since we just passed a very non-specific bill in the last session that nobody has decided what it's going to address about implicit bias, could you please address that in trying to, since that's one of the major determinants of not listening?
Thank you for mentioning that. Yes, Governor Whitner, I left in 22, maybe 21, and declared that anyone applying for a license through her state government, veterinarian, beautician, anybody, dentists, surgeons, doctors, everyone has to go through a mandatory implicit bias training, and the CDC is recommending that too. So the summer of George Floyd, I worked at Spectrum Health in Grand Rapids. They made all 60,000 of us sit down and take the test. And surprising to me, I had one bias. I thought I was perfect, but I try to love equally, but I had a bias, and then they had us repeat the testing in 6 months to see how you address that. So yes, I think it is important because we go through life living our lives and not realizing that all of our experiences are different, and some people do not have all of the advantages that other people have, and to self-reflect and look inward. I love Governor Whitmer. I'm a fan. She believes in women's rights and fight for women's rights. When Roe versus Wade reversed, she hit the ground running and mandating, we're still going to cover IVF. We're going to do this. So she's a great leader and she does great things. So I believe implicit bias training is important.
Thank you so much for speaking with us. I'm a minimally invasive GYN surgeon here at UC Health. And I'm a part of our DEI executive board, and we try to talk about implicit bias training. So just to piggyback off that other question, you had mentioned that they actually had you retest. What implementation or what programs do they have between your initial test and your secondary test to help you overcome those biases?
There wasn't anything formal. I think for me, it was just, I need to do better. But it was that summer what Spectrum Health, they're an amazing institution. What they did that summer and for a year is there was weekly book clubs and times to come together and reflect, and for Black people to have a voice and for everyone to listen. They had book sessions, they had meetings, they had, as the murders were happening, they would call emergency care meetings. What do you need? And that went on for a year nonstop. And then I left shortly thereafter. But for me, it didn't take anything else but for me to say, oh, you have now are all people going to be that self-reflective? But, it was just an eye opener for me. And with everything else that Spectrum was doing and in the lens that the country was under, You know, I hope it helped. I was at that point working in rural Michigan. I was the only, there were 3 Blacks, but like right at the beginning of COVID, the other 2 ancillary people were let go. And I did not realize till the beginning of COVID how isolated I was. And my family was mad when I finally came forward, but I didn't realize it till my manager actually sat me down and said, "Do you notice something different?" And I guess I, was living my little Black girl life in rural Michigan. And when I reflected on it, I was like, yeah, the nurses treat me different. When I walk around the neighborhood, the neighbors come out and,
Mhm.
talking and staring, but I hadn't realized it till all of that came to be. So I think it's difficult. It was just a self-reflection. They didn't give us anything more, but I know for myself, it was enough to kick myself and say, you got to fix that area. So, and I don't know what everyone else's scores were, if they made improvement, but I know personally I did.
So, first of all, that was a tour de force in a really tight time frame. So I really appreciate your talk. Um, I co-chair the AMA's Truth, Reconciliation, Healing, and Transformation Task Force. And I would love to hear you say more. Oh, so I was going to say thank you for mentioning Doctors Back to School, and just a pitch for everyone. It's not just for African American and other minoritized groups. If you are a white male doctor, you are also welcome, or student, you're also welcome to participate in that program. It's a wonderful experience. I'd like to hear more about trauma-informed care. Uh, I really I really wonder if that is one of the keys here on top of the implicit bias training and maybe that's a frame that more white physicians could accept than the framing of, don't be racist. But sort of to recognize the life experience of many Black women in America.
And I think that's a good point is we never know what everyone's day to day and what their life has been. So I agree that racism is a tough pill to swallow, but stepping back and accepting that people have had different life journeys and different traumas like adverse childhood events that came out 10 years ago. And now they're saying the adverse childhood event of the pregnant woman may impact the unborn child and in their life going forward. So I think that's a beautiful lens to maybe make things less in your face, to just say step back and accept that you haven't lived that experience. You don't know what that Black body's been through in front of you, and to maybe listen a little better and listen a little more carefully to make sure you're hearing what they say. I think that's a beautiful point.
Thanks. Kwaku Hazel, bariatric surgeon here at the University of Colorado. As always, excellent presentation. We do have a lot of work to do, but my question specifically is for Black men. So we are typically not the OBGYNs, the midwives, or the doulas, but we are certainly the fathers, the brothers, the sons, and the spouses. With your experience and your knowledge, where do we fit in, or have you identified any ways in which we can fit in and really help address this Black maternal health and infant mortality issue?
Think is just being present and being with your partner and being on the unit to be her voice is critical. There was a story I just read, I can't remember where, in the last week, where the mother said no, and the doctor kept talking to her about it. So the husband did just that. He crossed his arms and said, "My wife said no." The discussion stopped. He was bombarding the woman, but soon as the Black man stood up and said, "My wife said no." There are Black organizations. I know Kalamazoo had one for Black fathers. I think we just need to be involved. And there is, like you said, you're not the midwife, you're not the doula, but I think you just have to be present and supportive and help your wife in making the choices in the hospital she chooses, the doctor she chooses. And what I said yesterday, on Friday in the panel, is that not all of us plan our pregnancies, but if we can, to start choosing your provider when you're not pregnant. to start having your annual exams with your gynecologist to see if she hears you, to see if she sees you, to see if she's listening, to see if she addresses your hypertension and your diabetes and your obesity. So if you could help her in that process, even before pregnancy, planning for pregnancy allows optimization, especially if moms have hypertension, heart disease, and diabetes. And in choosing that hospital, you want to make sure if your wife or your partner has high-risk problems, that you choose a hospital that's best for their care. If your wife has a weak heart, don't go to rural Colorado and don't even come to Avista. I want you to deliver right here. I want you to deliver at PSL, where everything you need is at your fingertips. So I think based on a patient's risk factors, but that takes the team to make that decision. But my patients know, I've sent patients out on helicopters and ambulances to get here from Avista when I was like, no, you can't deliver here. And my team questions me. And then when the outcomes go the way they go, they're like, oh, we understand now. So I just think being involved, planning where you can plan, being a partner, being a voice. I tell every time I get a chance on Facebook or with my family, don't leave your family member. If someone's having surgery, it doesn't have to be an OB patient. Everyone has to work, but if you can be there and be that voice. When my ex-husband was sick, I was curled up on the bed, even when I was on call, just to be his voice. But for Black and brown moms on labor and delivery, where there's been violations and harms done, having, like when my niece delivered, I told my middle niece, do not leave the hospital till the two of them come home. Make sure. And then my sister called me. She's got a Black resident. She's got a Black student. And the baby had a Black pediatrician and a Hispanic pediatrician. She had the pediatrician crying, just telling her, thank you for being here, because it makes a difference. Because when you have brown and Black people in front of you, they're going to hear you a little different and have better chances at believing your concerns and listening to your concerns. But I think the most important thing is being there and supporting her and trying to plan so you can be optimized and be healthy. There is at the panel, I haven't read through it yet, so I haven't posted it. The Soul to Soul Sisters has a Black maternity guide that goes over all of this stuff. So as soon as I proof it, I'm going to post it and share it with the world. But Soul to Soul Sisters is an organization that works with reproductive justice and improving maternal mortality, just like Sister to Sister and Elephant Circle and Family Forward Resources and Birdie Johnson. They provide free doula care, and a lot of people don't know about that. So we just have to get the information out. And that's the importance. I've been talking nonstop since February, just getting the information out so that we can make a difference, so we can start conversations. And who else?
We have one on the floor, and then we have many on Zoom, so we can switch online. Nope.
You really struck me when you said you had the self-reflection to work on the one issue that had been challenging. And I think most medical schools and universities have an online course that you take on implicit bias. But I think very few of us take the time to be self-reflective on those kind of red flag issues. What would you suggest about follow-up? Because I think that's so important to do that self-reflection and to really dig into those things that are challenging for us.
In my hospital system at the time, when the 6-month test was done, I'm like, okay, what are the stats? Who's done it? Who's completed it? Has my office completed it? Because I mean, the place where I felt most isolated in Big Rapids, Michigan, wasn't the gas station or the grocery store and labor and delivery. It was my office, to the point none of them came to my going away party. The ones little Black girl did. All the nurses in the hospital came to my going away party. But I did inquire, who did the follow-up? Who did the work? And I think it needs to be like a mandatory process. It needs to be mandatory that you do step 1, and then in however 3, 6, 12, 9, 12 months, you need to do step 2. And I don't think the second one was mandatory. That's why I was inquiring, why isn't this mandatory? Why isn't it as important? And that was the year of George Floyd. So I think there should be some follow through. And I think it's important just for self-reflection, again, in a different way to look at things, to look inward, and to look at how you can make a difference.
And it should be mandatory.
Yes. I agree.
We're going to switch to my colleague Natasha, who's going to bring in some online questions.
Yeah, there are several online questions, but we're going to start with this first one. Thanks for your support of midwifery and doula care. Any comments on centering pregnancy care, group prenatal care?
So I do have an experience with that at Borges Medical Center in Kalamazoo, where I had the blessing to work for almost 9 years with midwives on a day-to-day basis. And they taught me so much. And literally, I'm in a Facebook group with them till this day. And they did do centering. And that's when a group of women, low risk, all come and do their practice, their visits together. And it was a joy. They enjoyed the patients enjoyed the support. The patients who were introverts and wouldn't ask the questions would learn knowledge because the extroverts weren't afraid to speak up. But it was a promising program that had good results. Unfortunately, Borges didn't keep up with it, but it is something that has been around. I don't know, does CU do that?
We actually, hi, I'm Lauren. I'm an OBGYN here, but we have a program very specific to the University of Colorado called P3, Pregnancy and Parenting Partners, which actually follows them through the first year of parenthood. And so if anybody's interested in group prenatal care, we have a very, very robust program.
Excellent, thank you.
Another question is, why do you think that the limited supply of midwives in the US is leading to such disproportionately high mortality rates in Black mothers and babies? Why aren't we seeing effects across the board? And do you think increasing the supply of midwives will specifically help Black mothers and babies?
So yes to the second question, I think it will help all mothers. The first question, can you state that again? It was a long question, the two of them.
Why aren't we seeing effects across the board and the disproportionately high mortality rates for Black mothers and babies?
I think that has to do with the list of why we're here. The weathering on the Black woman's body, the stress, the daily living of being Black in America, the discrimination, the lack of listening proven in studies. I think it all has to do with our existence in America and us not being heard. But as Dr. Brianna said on the panel, we also have higher likelihood of coming into pregnancy with obesity, diabetes, and hypertension. So that makes our pregnancies higher risk from the go.
What are some barriers you are facing to make this data heard medically or politically? And what can we do to help this fight?
Yes, that is my fight. We have a tri-chair position, so there's a psychiatrist who is Dr. Nagel here. Priscilla's a life experience member, and myself, and Dr. Bronwyn was the outgoing chairperson. And she sat us down for lunch and reviewed the politics of the CDPHE. So we are trying to figure out, because when I went to my first meeting in Michigan, I was like, okay, we know what happened. How do we get it out? But it's anonymous. We don't know the doctor. We don't know the hospital. So you can't go to Dr. Jones and say, hey, next time, can you not do this? So for me, being a doer, that's a challenging position to be in. And with the politics, I'm trying to negotiate that to see how we can get the information. These lectures and sharing the data from the MMRC, I think, is the best way that I have within my position to do. There is a maternal task force that takes our findings. We're the data collecting branch. They take our findings and move them into action. And we're trying to close the loop to work with Elephant Circle and Family Forward Resources and all the mental health organizations of how to, because like I said, overdose and mental health led to over half of the deaths for those 5 years. We have to close those loops and try to get the information out. But there's definitely, that person is wise, politics involved, unfortunately.
How can nurses advocate for Black pregnant women when the doctor isn't listening to their concerns about the patient?
So I remember I watched a video on, obviously Facebook, but anything that I feel is appropriate and important. And it was this white nurse just going through what she says to a Black woman when she meets her. She's like, I'm here. I hear you. I see you. I'm going to do everything I can for you. I want you to know that you're going to be heard, and I'm here to give you the care and the understanding and for you to have a healthy, it was just this dissertation that she says she goes through. And that's a lot, but I posted it because it was beautiful that a nurse took that time and energy to support a woman of color. But if it gets to the point where the patient's not being heard and things are being considered to be done to her without her permission, da 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 da, I believe in activating the chain of command. And I posted that too. If you're not getting what you need, you talk to the charge nurse, you talk to the house supervisor, which is usually a nurse, you talk to the chief medical officer, so usually it's going to be the charge nurse on the floor, the house supervisor, then you can get the physician lead in charge. You can call the risk management office. So there is specifically a chain of command that not all hospitals have laid out, but you start with the floor and then you escalate it however you have to. And one time when the preeclampsia findings, the new ones came out in 2008, I had the chain of command in my whole career activated on me. And it was new information, and the nurses weren't sure why I was delivering 34-week twins, and they were all up in arms. So my chairman called me, "Can you explain what's going on?" And I'm like, "Well, according to the April 8th data that came out 2 weeks ago, these are the new recommendations," and the nurses weren't up to date. But the chain of command, usually if it's a nursing issue, you go up the nursing chain of command. If it's a physician issue, you go to their bosses. But if the nurses aren't hearing you, then another way to get attention, if a patient and family feels they're not being heard, push the code button. You're going to have 8 to 10 people at your bedside within 5 minutes. Someone's going to listen. I saw that in an article. And if it's critical, if it's a dangerous point, and or you've been beating your head against the wall for 3-5 hours and nobody's listening, that will get everybody in the room, not the chief medical officer, but the entire code team. So
As Katie mentioned, there were more than 100 people online, and everybody's just been commenting on what a great presentation this was. So I just wanted to make sure that you heard that from the folks online. And we're just one last question here is, I want to ask if you feel, what you feel is the most preventable portion of these maternal deaths. Also, I'm studying sex differences in heart failure, which I understand plays a role in the maternal mortality rate. I was curious if you feel that there should be more research in understanding the intersectionality of race and sex in heart failure, especially while pregnant.
cardiologists are my best friends during pregnancy. If I see a patient once and she's kind of having complaints, depending on the severity, if she still has those complaints, I send patients to the cardiologist all the time, to MFM all the time. Because of where I've worked, I've not worked at a major hospital that's had everything probably since 2019, and it still didn't have everything like the university. So I practice safe obstetrics. I want healthy baby, healthy mom. And if I can't give them what they need, then they need to transfer. And definitely more research is needed. The FDA just approved on letting moms and pregnant women in drug studies, which is going to be a hard sell, but it's the movement in the right direction. Cardiomyopathy, I have had patients with, when I was at my tiny hospital in Michigan, I felt like I was on an episode of ER. I had to push a mom onto a helicopter, 2 of them, one for a stroke and one for cardiomyopathy. And what we are finding, we were just talking about it, and I'm studying for my annual exam. I feel like preeclampsia is becoming an epidemic. At the beginning of our careers, we were taught the Black, the young, the smokers, the old. Now it's everyone, all races. And I went to bed this last week thinking on call that it's everywhere. It's not just mild preeclampsia anymore. It's severe preeclampsia. Are you guys seeing it here where you're seeing more severe preeclampsia? And that was pre-COVID. So I don't know if we can blame it on COVID, but any day out at a Vista, we'll have 4 to 6 MAG patients. 2 of them are postpartum coming back. So yeah, cardiology research is important. And I knew I was going to forget the first half of that question.
I think it was just the importance of the mortality rates and any.
What's the most important thing to do, or how to make the most impact? Again, I think planning, prevention, exercise, weight loss, control your hypertension. Oh, one important thing I said at the panel, please don't stop your psychiatric medicines. There are very few psych medicines that aren't safe in pregnancy. Please do not stop your psych medicines, because you could be 110 pounds, have no risk factors, but you stop your depression meds, you're up here with the diabetic and the hypertensive and the preeclamptic. So that's one thing I didn't mention. So I think prevention, education, being selective in your doctor and who you choose, I think can all, in the long run, affect outcomes. But again, I think the frontline people need to be hearing, listening, and seeing. And when I saw that Geronimus study about our DNA being 7.5 years later, immediately I'm doing the math. So I'm like, 35 means 20. Are we going to start treating Black moms like AMA in their late 20s? You know, how are we going to use this DNA science? So I think systemically, you know, policies and plans in place to make sure moms get the care they need, to make sure they know there's free doulas, to make sure Colorado continues to be a fighter and frontline for reproductive justice and for women's rights, I think is key. Thank you, ladies.
All right, we have reached the end of our session. Dr. Owens-Robinson, we are so grateful to have you as a friend of our center, of the Anschutz campus and the CU system.
Thank you
And I
for
think I
having me.
speak for everyone here that we welcome you anytime. I hope that those of you in the room, if you have a moment after the talk today, to come by our gallery just outside the door here to see the work of Nedra Bonds, as well as read the history of Justina Ford. And for those of you online, do come by when you can. Thank you so much.